Welcome everybody. This is the fourth session of our 8-week series of the Taping and Movement series brought to you by Elastoplast. All sessions are free, and there's been a great lineup of industry professionals from a variety of sporting backgrounds that have been organised by Elastoplast, so it's a great initiative. And thank you for putting aside some time on a Wednesday night to come and join me. My name's Tristan Chai. I am the Director of Good Physio, which is a physio clinic in Adelaide. We have a clinic in Glenelg, and our team down there look after a bunch of people from all walks of life, athletes all the way through to your elderly athletes and your young ones too. So on top of this, I'm also the head physiotherapist at the Adelaide 36ers basketball club. So today I wanted to talk a little bit about ACL rehab, which is a massive, massive subject. So we'll get through as much as we can and go from there. I want to go through what I want to say and give you some good tips and ideas on the latest research, but I also want to open up as much question time as we can at the end, because I think that's where we will find the real value when we start opening the discussion a little bit more. Before we start today's session, there's a little bit of housekeeping. We have two Elastoplast representatives controlling today's session, and if you have any questions, please direct them in the chat forum. Because we have so many people in today's session, everyone will remain on mute until such a time when the floor is opened for questioning. If you have a question in question time, please virtually raise your hand and the Elastoplast representative will take you off mute to ask the question. We apologise in advance if there's not enough time to get to everyone's questions, but we will try our best. This particular session, I'm not plugging any specific Elastoplast products as such, and I rate that from the Elastoplast group because this is more an informative session for our community of sports trainers, physios, and sports medicine practitioners, rather than sort of a plug of product. This is just good information that's worth knowing because of the nature of our work that we're in. On that note, though, when you're using Elastoplast products, always read the label, follow the instructions for use, and if symptoms persist, talk to a health professional. So we're going to talk about ACLs. You've heard about me, so my experience with ACLs comes from a range of categories, from elite professional athletes all the way through to your amateur footballers, and then all the way through to just your recreational fitness people. So I've had a broad range of it with a broad range of goals and commitment to rehab. So I've had a fair bit of experience with it over the years, and I enjoy treating them because it's quite a journey you've got to take with these clients. So let's talk a little bit about the injury. So first of all, what is the ACL? We hear about it a lot. It's in the media a ton. The ACL is the primary stabilizer of the knee. Ultimately, it's a ligament within the knee joint. It crosses over with the posterior cruciate ligament and stabilizes the knee. What we know about the injuries is that it occurs more in females, almost twice as much, 1.7 times as much to be exact. And we also know that they're being diagnosed at a younger and younger age. So it's been reported as young as 5-year-old kids sustaining injuries and ruptures to their ACLs. It's really common in sports that require agility over objects, so think gymnastics and jumping. And the incidence is higher in contact sports versus non-contact sports. So in netballs, footballs, basketballs, or a high incidence. The interesting thing with that is that there's also a high incidence. The actual injury itself doesn't always happen from contact itself. It happens from your cutting movements and your change of direction kind of movements. So there's a high incidence in European handball, for example, when you're trying to dodge and weave someone or fake someone out. A lot will happen within that. So usually there's that kind of mechanism that brings it on. The most common movement pattern is a fixed foot. So your foot's planted, your knee's slightly bent, slightly inwards, and then there's a rotational force that goes about that, whether that's someone tackling you or whether it's just your upper body changing direction and that momentum that shifts your upper body on your tibia. So this will often be described as by the player as a buckling or a giving way, and in real time, from the sideline, it's sometimes hard to see the mechanism realistically. If you're watching the game, it's hard to watch every player every single time, so you'll see someone go down, so you won't see the mechanism. And even if you were looking at the exact thing without the beauty of a replay when you're watching things live, you won't necessarily know what's actually happened. But usually they'll describe a buckling or giving way. Sometimes they'll feel a pop, and they'll be in a lot of pain. As is the picture there with Clay Thompson when he did his clutching at his knee. It's quite common for it to be very painful. It'll swell up within a couple of hours. And if there's a sports doc or a physio handy, they'll usually test the stability of the knee with a number of tests, usually a Lockman's test, which you'll see quite often on TV, on the AFL games. That'll be the first thing they'll try and do, or a pivot shift test. They're probably the two most sensitive that will get you understanding what's happening with the ACL. Okay. So that's about the injury. If after you've quizzed the player, they've swollen up, they're in pain, and you may have tested a Lockman's or a physio or a doc that's with you has tested their knee, and they're a bit suspicious that there might be some level of instability there. The general way it goes then is they'll be sent off to a doctor or sent off for an MRI to confirm that diagnosis. If you're a sports trainer, I understand we've got a fair few sports trainers in the room. This might mean that your best bet is to refer them off to a doctor with your own suspicion that, hey, they buckled, they're feeling a bit unstable, they swell up pretty quick. I'm concerned about the ACL. Do you think we can get an MRI and get that organised? Usually they're in a lot of pain and want some sort of answer sooner rather than later, which is fun because we had one on the weekend at a women's football game, and sometimes it's not that easy to get organised an MRI over the weekend, so there's a couple of days of just being their friend and being supportive to them. So that's how we'll diagnose it generally. Also with an MRI, it'll tell us if there's other injuries within that knee that need to be addressed as well. So once you've had the MRI and everything's been confirmed, we have a very interesting decision-making process to go after that. And this has become really interesting over the last sort of 5 to 10 years. Continues to get more and more interesting because typically it's been the culture of ACL injuries and competitive sport and elite sport has been, let's get in there and get it fixed up. So I think there's because of that culture and the way that that's been bred into us over the years, I think it's important to take a little step back and recognise everything that's been going on in the world of ACL research, and have a think about how best to manage it going forward. So I want to try and arm you guys with some useful information, because you've got an athlete in front of you that has done their ACL and they're confused and emotional, and there's a whole bunch of things going on in their mind. They want to get back to sport, usually in the quickest way possible. Sometimes they don't, and they're just really, really scared about what surgery might look like or whatever. So it's important to stay calm. But it used to be such a given that you do your ACL and you're looking for surgery, but really there's 4 realistic options that need to be discussed. And one is surgery at the next logical availability. 2 would be surgery after a period of rest and rehab. 3 would be no surgery and then try and rehab it without an ACL reconstruction and try and return to sport from there. And the 4th option would be non-surgical rehab, and then just adjust your lifestyle accordingly. So that might be for someone that's a bit older that finished their sport, they're happy just going back into running and non-competitive agility work. Okay, so you've got 2 options where there might be surgery soon, delayed surgery, or 2 options where there's no surgery at all. Okay. Every individual has a different story. So one thing I won't do is stand here and say what the best option is, because it's really dependent on the person and their exact diagnosis, and whether there's other things going on in the knee that might need to be looked at as well. But the general consensus, though, is that a decision doesn't really have to be rushed, and we can wait for the knee to quieten down before making a decision on how to manage it. That means we can also wait for a few emotions to quiet down, and we can make a level-headed decision. It's pretty important to note that there's not a great deal of evidence suggesting that people should rush into surgery ASAP, i.e. the next day. I mean, I think it's probably a knee-jerk reaction that you know that something's ruptured in your knee, so you want to get it fixed as soon as possible so you can start the healing as soon as possible. But there's a number of case studies around that sort of suggest that if you jump straight into surgery while the knee's angry, it's swollen, and you traumatise it with surgery, the prognosis from there is quite poor. It takes a longer time to get it moving, takes a longer time to get the range of motion back, and then takes a longer time to get strength, et cetera, et cetera. So you can be safe to delay it while you sort out the headspace, while the player sorts out their headspace. In most cases, I think option 2 or 3 are the best things. So surgery, delayed surgery, so you get some rest and rehabbing. I think both of these cases sort of overlap a fair bit. There should be some supervised prehab after you've done the injury, but before surgery. And in this time, when I say supervised prehab, that means the exercises have to be of high quality, supervised with some goals in mind, to see how an athlete is coping without an ACL. So if you've done your injury, you've settled some swelling, you've iced, you've compressed, it's starting to feel like a knee that's functional again, which might be a week down the track, then you start exercising it, get strengthening going, get some movement back into it, get walking and doing all your activities of daily life. You'll find that from there's 2 possible scenarios. Either the knee's not responding really well to conservative management, so you're trying to get it stronger, but it's still collapsing on you when you're walking down the street, or you know that it's not going to hold up to where you want to be. It's going too slow for what you what you have in mind for it. And then you can go into surgery with a knee that's settled down with some rehab that's already done. In that kind of case, you haven't wasted your time by waiting. You've actually prioritised some prehab before the surgery, which is ideal, and then gone into surgery. You'll come out of surgery with a better baseline that you can still work on. So it's absolutely not any time wasting going on there. And then in some cases, you'll find that if you do all of this prehab, it actually starts to feel pretty good. And then you can start to do more and start to progress things, start running. And there's been a lot of cases now where a non-surgical knee has been rehabbed back to sport at all levels. So there's been a English Premier League player that got back playing within 8 weeks. There's also been MRI studies that have shown some healing of the ruptured ACL without having surgery. So it's a worthwhile cause to see how your knee holds up and to make sure that if surgery is the option, if surgery ends up being the option, that you've done everything in the meantime to try and make that work. Okay. And there's a few studies now that back that up on my slide there. I hope you can see the slide. There's two studies that have backed that up. One's the Canon study, and the other one is more recently the Dutch Compare trial, which basically say 3 to 6 months of quality rehab is the best practice at the moment, and then opt for an ACL reconstruction if an instability develops. So this will be if the desired stability of the knee has not been demonstrated in that 3 to 6 month period. You've got lack of confidence or lack of function, then you can opt for the surgery. The thinking is there's nothing to lose, because even though, once again, you're not wasting that time, you're doing some quality rehab that then holds you in good stead for the rehab post-surgical. And it's been demonstrated that the people that do good rehab beforehand catch up when they do rehab post-surgically as well. So there's a lot to think about there, and as much as that's probably the options that I go through with my clients when I see them, is that they don't have to rush into it. I also encourage them to, talk to surgeons, see what their opinion is, talk to family and friends, see what their opinion is. But I think it's important that from a coalface perspective, if we're physios working with the club, sports trainers working with the club, coaches working with the club, that we're armed with enough knowledge to go, hey, it doesn't necessarily mean this, doesn't mean it's not that, but all the options have to be laid out on the table, I think, and allow them to make the decision that's best for them. So it's a big thing that's being shifted in the physio world at the moment, is to try and encourage that initial pre-op phase to be extended a little bit and see what the knee can do without an ACL before we rush into reconstructing it. There's some pretty neat indicators of whether they're going to cope or not, and there's a few questionnaires and whatnot, but the people that tend to cope, usually their swelling subside. It's a pretty clean ACL rupture. There's not too many other injuries in there, like a meniscus tear or cartilage damage. But the people that tend to cope pretty well are the ones that swelling subsides pretty quickly. They're not fearful of using it at all, and they just generally have better dynamic stability of the knee. And it's anyone's guess who that might be. It's not like you can look at someone and say, hey, if they ever did their ACL, they'll be good. It's just you can't see until you see, and that's why we need that 3 to 6 months to work out that particular person. So there's a bit of problem solving that takes place, and I'm sure if you haven't been through that already with someone at some point throughout your career, you'll get some questioning, and there's a lot out there to consider increasingly. So I've said the term quiet knee a couple of times. What is a quiet knee? A quiet knee is full range of motion, little or no swelling, no quads lag. So if you unaware what quads lag is, if you were sitting on the edge of a bed and lifted your knee straight, the lag is how much is off of being straight. So when after you've had surgery or after you've had an injury to the knee and the muscles aren't working quite right, you'll find you can't straighten quite straight after the muscle wastage and stuff. So that's going to be important that comes back, and also little to no pain. So a quiet knee. So we want a quiet knee to see how it functions pre-surgery. We also, throughout the rehab process, whether it's post-surgically or non-surgically, we're going to return to this concept of a quiet knee. We don't want to increase running on a knee that's grumpy. We don't want to increase exercises too quickly on a knee that's angry with us. So it's an important consideration throughout the whole rehab process, this concept of a quiet knee. So we've got this, once whatever we've chosen recovery management wise, we've got this long and windy road of recovery that's requires patience from therapists and the athlete, and it is long and windy. There's sharp corners and there's straight roads and there's a bit of everything. So it's always a bit of a mixed bag. And I do enjoy treating these ACL clients because I do get to know them quite well over this time, and they get to know me quite well too. So I enjoy taking that journey with them, and there's never really a dull moment. So one of, I think when I started, I've been a physio now for 15 years, and when I started in the industry, a lot of what we based ACL rehab on was a time-based rehab program where you're back in 12 months. First 3 months is post-op and getting some knee range of motion. 3 to 6 months, you're starting your running. 6 to 9 months, there's a bit more sports-specific agility, and then 9 to 12 months is you're back training, and 12 months you're back. It just magically happened like that. And then this clever bunch out of Melbourne, Randall Cooper and Mick Hughes, put together a really good resource that I recommend everyone gets on board a little bit, and that's the Melbourne ACL Rehab Guide, which takes into consideration the criteria-based rehab. So you don't get to a date and that gives you the green light to go ahead. You have to tick certain points. So I use this a fair bit. I give it to my clients as well, so they can see where they're heading and the kind of detail that we're going to need to go into. So this separates it into phases pretty well. This guide's available online, pretty readily available, and I think it's only a few bucks to download it. So I recommend it if you come across any ACL rehab clients or players in your team, because I just think it's a great resource. I'll run you through it a little bit. I'm not sure how well that shows up, but here we've got basically 5 phases, 6 phases if you count pre-op. So the first phase is pre-op, however long that takes to get to the op, obviously. But here you're trying to recover from the injury and prepare for surgery and rehab. And at the highest level that you can do that is great because, as we just mentioned, it buys you time to make your decision about surgery, and also it'll give you the best chance of rehab once you're out of surgery, if that's the road you go down. Phase 1 The official phase 1 is recovering from surgery, and that's all about regaining your range of motion in your knee, so you're bending and straightening, and beginning some strength work. So you're trying to get rid of that quad lag. Okay. So in the guide, it'll take you through, these are what you want to get through. You still do it with a physio so they can assess you individually. But to get out of phase 1, you want range from 0 degrees. So you want to be able to get your knee straight. You don't want it to be stuck in a little bent position. You want to get it to 125 degrees or above. In flexion, so you want to be able to bend it a fair bit, and you want to have no quads lag. Okay. Get rid of those, pass those tests, then you can go on to phase 2. So it doesn't give you okay, you've been struggling with this knee for long enough, now let's get you on a phase 2. It's once you tick that box, you go to the next one. So phase 2 is strengthen neuromuscular control, which is about regaining some single leg control, some balance, regaining muscle strength, and getting a good single leg squat in. And then you need to pass a larger range of tests, so things like single leg bridging, calf raises, and things like that. You have to pass with, you have to get at least 20 on each side, and you have to be within a certain range of each side. So we talk about a limb symmetry index. So you take calf raises, for example. If you can do 25 on your non-injured leg, then you'd want to get 85% of 25 on your injured leg. Okay, so you want to be getting 22 or 21. But if you can only do 12 on your injured leg, then you've got a little bit more work to do. So you'll stay in that phase for a bit longer and build up strength. They've also got a exit criteria there of squatting in the gym 1.5 times your body weight, et cetera, et cetera. So it goes into a fair bit of detail. Once you exit that, then you can get into running agility and landings. And this is where, for me, it always fell down back in the timed model of rehab, is that 3 or 4 months would tick over. They would have a horrible single leg squat if you're looking at them, their knees falling in, they're not balanced and stuff, and you're sending them out to running because the time was right instead of the person being right. And what we find with these phases, they're so elastic that you might do one phase really, really slow, but then the next phase comes through really quick, and then you're on to the next phase, and it all balances out in the end. But the last thing we want to do is send someone back out of sport simply because 12 months is up and there's been not any great improvement along that time. So this is a lot better. Phase 3 is running and agility work. That's where we get into a bit of a hop test battery, and testing that once again. If you may have seen a diagram like this, this is quite a common hop test battery of tests. Single hop and land, triple hop, so you're hopping 3 times and sticking a landing, crossing over and hopping, and then the timed hop over 6 meters. These are quite good, but again, as we get through to phase 3 and 4, a little bit of common sense comes into it, because just like I said, the timed model of coming back to sport, this in itself has a few little faults that we need to make sure that we stay on top of. So just because someone can single hop and it's within 85%, so if you don't know this test, for example, single hop, you hop as far as you can and you stick the landing, okay? So that means you can't put your other foot down, you can't sort of shuffle your foot to get your balance, you're hopping and sticking, okay? But there's a hop and a stick, and there's a hop and a stick with your arms flailing and stuff like that, or your knee internal rotating, and there's stuff that you can't measure with a tape measure. You use your eyes and you have to use your common sense whether you're happy with that going forward. So this is where some common sense comes into phase 3 and phase 4 of this. So phase three of getting these hot tests done, they might get 85-90% of their limb symmetry index, but not look that good. Same with return to sport. They may tick a number of boxes to be able to get there, but still not look very confident out there. So a bit of common sense comes into that. And a lot of communication with the coach and the player as well. But going through that process, I think it's important to know that that's what we're doing in the background. If you're a trainer at a club and you're seeing someone through their rehab a little bit, you'll probably jump in at this sort of phase 3, 4. That's when I'll probably be back out at the club a little bit more, trying to get some running in and trying to get some teamwork in. And hopefully some of this has been done in the background. And if not, I think we need to question it and maybe make sure that high quality rehab is in there before they take the field too much. Okay. And that's also where the return to sport stuff comes through pretty hard. We physios, if it's not a professional club or if you haven't got a physio at your amateur club, it's really reliant on the people at the club. Sports trainers become the primary health professional there, and it's going to be relying on the coaches. We have to handle a lot of this just because logistically we can't be at all the trainings or all the sessions that our players and clients go through. So we have to depend a lot on communication back and forth with the staff at the club. This part of this phase of rehab is super, super individualized. It's going to depend a lot on the sport and how confident they are. And we get through that on a case-by-case basis. Then finally, from my structured part of this talk, is the psychological effect. It would be amiss of me not to mention it because it's something we come across a fair bit. You tend to be a psychologist if you are a physio or a hairdresser or whatever. If you spend a lot of time with someone and help them through something, there's definitely a psychological aspect that you become involved with. So there's some formalized things that you can do. It's suggested that you give them some fear of movement, ACL return to sport kind of questionnaires to do on a 6-week, couple-month basis, just to see how they're tracking and how confident they are. From a real-world scenario, it's funny, I get a lot of patients that will lie down on the bed and they'll be week 2 into their rehab and they're just like, I just don't feel comfortable that I can get back out there and play sport. And it's funny because I'm not asking them to 2 weeks. And I think they're looking so far ahead that sometimes it can be really daunting and affect them quite hard. I think I lend a friendly ear, but I also think that high-level physical rehab helps them to build trust back in their knee. And if we can keep them focused on just the next step that they've got to take and the next rehab step, then we can move on from there. And that's what gives them their confidence. And then the second thing is sometimes you just need to be a friendly ear for them. There's a lot of support they need. Every individual is a little bit different when they're coming back from for their career or whether they're coming back from leisure. It doesn't really make a difference how much this injury means to them and how much rehab is important to them. So, I mean, that concludes my structured part of what I wanted to cover today. But I really want to open the floor for questioning to hear any experiences or anything that's come up in today's talk that you guys might want to talk about, any specifics that you want to dive a little bit deeper into. Please feel completely free to jump in. while you have a think about that, one of the things that springs to my mind when uh, is that phase where they've just done the injury and they're not quite sure what they're going to do. I think I've had multiple experiences where you've had athletes in tears trying to work out what to do. A team approach where you talk to their parents, you talk to them, they talk to a surgeon. Sometimes they don't get a great reception from the surgeons are busy and they have one way to do things. So sometimes it's nice to get a few opinions along the way. We've got a question come through. Are you using any specific tools for rehab? We use a bunch of different things. In the early stage of rehab, we'll use rehab bands a fair bit to just add that little bit of resistance without risking the knee. So you're making things a little bit more dynamic and challenging by way of a rehab band on tension, and then doing your exercises from there. A lot of the exercise can actually be done with body weight. There's a wide range of what you can do. I find bands super easy to use and good because they can take it home. So people that don't have access to a gym can have a band at home, and we can get creative in a whole bunch of ways to help them challenge their balance and challenge their muscles a little bit more. Okay, another question has come through. If you've had an ACL injury, the MCL and PCL are compensating. How are these other two able to heal at the same time? Interesting question. The MCL and PCL, if they're intact, they'll be doing their job. And what actually, in my opinion, what actually compensates more is the muscles around the knee to add that element of stability. Yes, there'll be some instability that the PCL and MCL have to build up if they're injured. If you've got multiple injuries from the initial ACL injury, then you're right, it might not be enough to be stable, which might send you down the surgical route. That might be the decision that gets made a little bit quicker there. But you'll find just because the ACL is injured, it wouldn't necessarily lead to the MCL and PCL getting injured because the ACL is injured. You'll find the compensation usually happens with the muscles around the knee, muscles around the hip, and if they can build up and if they're genetically strong enough, you'll have a good cope with the knee. Another question, what do you think of blood flow restriction application for ACL rehab, early stage, pre-surgery, post-surgery? Thanks, Ross. That's a great question. I'm using it a lot at the moment for this kind of thing. I really do like it. Why do I like it? I think it gives a good, it means we can lower the load and increase the effect on the muscle, which is great. I've also found in patients across the board that if they're having trouble activating a muscle, sometimes this will just give them that feeling that it's working a little bit more. So you get a little bit better uptake and a better result because of that. So I'm using it a fair bit at the moment. I like it a lot. So I'll use it. I probably haven't used it pre-surgery a hell of a lot, but I've used it post-surgery often. Okay, another question. What are your thoughts on knee supports, braces, taping during the rehab process and going back to sport? I don't love the idea of having a brace for this kind of thing. I think the process of ACLs is step by step. So the big thing is you want to build trust in the knee. I think it's hard to build trust if there's a big brace on it. In terms of supports and taping, I'll use maybe a tubey grip type thing to limit swelling. You might use your K-tape techniques to limit swelling. Taping, I think, if there's secondary patellofemoral joint syndrome stuff going on, I'll definitely take for that, because I don't want secondary pain coming in when the process is painful enough. So I find that PFJ syndrome type stuff that comes in is super painful for these people and gets in the way of their progress with rehab. So I'd love to take that up and get that sorted quick smart so we can continue on. So we'll use taping for that mainly. So mainly for the secondary stuff, not just support what the graft has done. I hope that answers that question. Proprioceptive exercises. So what sort of proprioceptive exercises would you prescribe? So there's a lot. I do a lot of single leg stuff. So single leg with movement might be a single leg squat. Depending where they're starting from, sometimes we just need to start with some single leg balance on various surfaces, soft surfaces, and then adding movement. That might be a quarter squat movement, or it might be an arm movement, catching and throwing a ball. So they're sort of your initial stage proprioceptive exercises. You can bring a lot of sort of foot awareness into those exercises and try and dome the arch and make sure that the weight through the foot's going well, and bring their focus to other areas. I'm a big fan of, as rehab goes down the track a little bit more, I'm a big fan of perturbation type stuff. So they're standing on one leg and you might give them a little TheraBand that you're there tugging away at, and they've got to keep their balance. Or the perturbation hop stuff. I'm not sure if you've seen that, but hopping and landing, but you get pushed in the air a little bit, so you're having to land and you're not sure where you're going to get pushed. I think some of that reactive stuff is super important, sort of in that phase 3 to 4, getting back into sport type stuff, and really good as I think prevention as well, as a warm up and readiness for sport, which is really what the final phase of rehab is implementing a return to play injury prevention program. So I really like it for that too. Perturbation hops. Brilliant. Those were some great questions. I am getting the wind up here, so I think we will have to end it there. I've got my little script out here, but for any Elastoplast products, please go to your local pharmacy or local sports wholesaler, or go to elastoplastsport.com.au, where you can purchase all the Elastoplast and Luco products online. For further instructional videos, visit Elastoplast YouTube page, search Elastoplast ANZ. Subscribe and like, plus you'll see all the videos from the other sessions in this Elastoplast taping and movement series. The next session will be on the 9th of June at 6 p.m. Eastern Standard Time with Gold Coast Suns physio Robert Brown, and he's going to discuss posterior lateral corner injuries of the knee. That's all we've got for you today. Thank you for your time, and please feel free to reach out with anything at all at any time. My email is always open. Take care and have a good night.